Well, good afternoon, ladies and gentlemen, and a warm welcome from Cape Town. My name is Peter de Jong, and I'm going to be the host this afternoon. Our hostess, that's Professor Steve Jeffrey. Unfortunately, he's in Abu Dhabi, so he can't be with me today, but he sends his apologies, and he will be logging on from Abu Dhabi. Now, it's a special occasion we have with us this afternoon, Dr. Percy Moodley. And are you hearing us, Karen?
Yes, here is all fine.
Well, we'd like to thank Dr. Percy Moodley for being with us this afternoon, and he's going to be speaking about the individualization of hormonal therapy in menopause. It's a beautiful day here from Cape Town, not a cloud in the sky, beautifully warm, 26 degrees Celsius, and everything is quiet outside and beautiful. It's quiet mainly because of the taxi strike. But apart from that, I'd like to thank Karen and, of course, Nadir. Nadir, do you want to come and show your face here? Can you see Nadir?
No pressure.
Nadir, can we see you? Do you see him
yes,
there?
Yes, it's all fine.
There we go, Nadir.
Hi,
and a special thank you then to Karen and Nadir. But in a special thank you also, ladies and gentlemen, bye-bye, Nadir, to Devon and Crescent from Abbott, because they indeed are the sponsors this afternoon. And we have well over 259 people here logged on this afternoon, Crescent. So I think it's because of the popularity of Percy Moodley myself. They thought he was someone else. So Percy, I'd like to introduce you. He's got an MBCHB, a fellowship of the Royal College, fellowship of the College of Medicine of South Africa, FCOG, and in fact is also a fellow of the European College of Sexual Medicine. Those of you that were with us last week, we had a wonderful talk by Elna Rudolph, and that was Sex in the Menopause. And she also, in fact, is the president of the European Society of Sexual Medicine. And that's where Percy gets his interests from. So, ladies and gentlemen, next week, we're going to have Professor Steve Jeffrey back from Abu Dhabi, hopefully. And our topic next week is, in fact, recurrent urinary tract infections, and that's going to be sponsored by Astellas. So without further wasting of time, I'd like Dr. Percy Moodley, who's very kindly agreed to share his screen with us and also allow questions on the fly. And also a special thank you to the Pelvic Floor Foundation of South Africa with Nadir of being with us this afternoon and sponsoring this in addition to Abbott. So Percy, would you mind sharing your screen with us? We look greatly forward to the individualization of hormonal therapy in the menopause. Thank you very much indeed. Now you just have to press something there, full screen.
If you go to slideshow, yes. There you go. Excellent.
Thank you very much for giving me the privilege of addressing you all this afternoon. The first slide is just a disclaimer slide that Abbott, although sponsored this thing, has not interfered with the content of the presentation. So as an introduction, there's robust evidence that estrogen is highly effective treatment for hot flushes and the genitourinary syndrome of menopause. And if it's initiated before the age of 60 years or within 10 years of the menopause, it's effective in reducing mortality, all-cause mortality, prevents coronary artery disease and hip fractures. But there's been a significant drop in hormone therapy use from 2002 when the Women's Health Initiative study was released. And it's based on patient fear, misunderstanding of the risk-benefit ratio, and lack of appropriate education of providers. So the symptoms and signs that patients have vary according to the stage of reproductive aging. And around the perimenopause, vasomotor symptoms, sleep disorders, and mood changes predominate. And just prior to the last menstrual period, menstrual disorders are common. In the first 10 years, urogenital atrophy and dyspareunia come on board, and later on, we have the late manifestations of osteoporosis, atherosclerosis, coronary artery, and cerebrovascular disease. So in the past, we recommended it for all women as soon as they reach the menopause and even in the perimenopause. But today we say that it should only be used for definite indications, constantly weighing up the benefit versus the risk, especially if you're using it in a preventative role. So what are the indications for hormone therapy to reduce menopausal symptoms? It's the only recognized treatment for osteopenia, for the prevention of osteoporosis, improvement of sexual function, effective treatment of genitourinary syndrome of menopause, and it may reduce the incidence of cardiovascular disease. But if you look at what is the perception of the leading causes of death by women, they would give you breast cancer. But when in reality, it is actually heart disease. So when asked to rank health concerns, women and healthcare providers place breast cancer at the top of the list. There are large observational cohorts reflecting the use of estradiol and a variety of progestogens. And these observational studies showed us that micronized progestogen has no or very little risk, and the synthetic progestogens, the risk varied by class. So in other words, breast cancer risk is dependent on the specific treatment chosen, mainly the choice of the progestogen component, which is only needed to prevent endometrial hyperplasia in women with intact uteri.
Percy, we've
Yes,
had
sir.
one question here.
Yeah.
Just go back to that slide, the previous one you've just shown us now. There we go.
Yeah.
That's it. That's the one. Person over here, anonymous from Kenya, said, what's the difference between micronized progesterone and synthetic progestogens?
Yes, that's coming up. I'm going
okay.
discuss a
All
few
right,
basic slides.
We'll come. That's Habib from Kenya, but he wishes to remain anonymous. So we'll come back to them in the course of this talk. Thank you.
Thank you. So if you look at the Women's Health Initiative study, it focused on women well beyond the menopause. The average age of the patients, of the study participants was 63 years. And the reason they chose the older population was that the primary study outcome of the WHI study was to look at coronary artery disease. And therefore, they needed an older population in order to power the study properly. And so what were the major outcomes of it? It showed increase in heart disease in the first year with a decreased trend over time, and an increase in incidence of breast cancer beginning at 3 years. So there were two arms to the WHI study. It was using conjugated equine estrogens, and the medroxyprogesterone acetate was the progestogen used. And this was stopped in 2002 after 5.6 years of median intervention. And the estrogen-only trial was stopped in 2004. So in summary, the WHI study was a well-designed clinical trial, but unfortunately it was done on the wrong population. It's not the age of the patients that us clinicians treat for menopausal symptoms. But it does deserve credit for demonstrating that hormone therapy in older and higher risk women to prevent cardiovascular disease and dementia is not supported by scientific evidence. So the hormones commonly used in menopausal medicine are estrogen, progestogens, and androgens.
Percy, another question here.
So,
go back, please. The question is, you say it was stopped for the combination after 5.3 years, and the estrogen arm was stopped after 7.2. But why did they stop it? The question is, why was the WHI study stopped?
So when they stopped it with the combined thing, if I go back one further slide, the major outcomes in the study was to look at breast cancer was the adverse outcome. And when the breast cancer, incidence of breast cancer crossed their threshold in the study, that's when they stopped the study.
Are you saying that this caused more breast cancer?
No, what I'm saying is that the major outcomes they were looking for the benefit was to see whether it had any influence on coronary artery disease. And the adverse outcome of the study was to look at the breast cancer incidence, the negative in the study. So when they noticed that the incidence of breast cancer was increasing, they stopped the study.
All right.
So that's why they stopped it in 2004. In 2002, because in the combined arm, they found a bigger increase in the incidence of breast cancer compared to the estrogen-only arm.
Okay.
And as we go further, this will come out clearer.
So why did they stop the estrogen-only arm?
Because they found that there was an increase in coronary artery disease in the first year after they. So there was an increase in the incidence of coronary artery disease in the first year, which decreased over time. But because it was increasing in the first year, this increase, they felt that they were not getting the benefit that they desired.
Okay.
Yeah.
Thank you.
Okay. So let's go back here. So I said the 3 hormones, but I'm not talking about androgens in any way today. That's a separate topic on its own. And if we do it at one stage, it'll complement the webinar that Dr. Alna Rudolph spoke last week. So we're going to just discuss some basic science first here now. So in the estrogens, we have different formulations. The 17-beta estradiol is the body identical estrogen, and it's the metabolically active estrogen produced by the ovaries in the human females. It comes from a base molecule called diagesin, which is cholesterol-like. Whereas in the Women's Health Initiative study, we use conjugated equine estrogens, which is a mixture of estrogen-like compounds. And some of them have what we call SERM-like effects, selective estrogen receptor modulator effects. And I'll allude to this later in the presentation. So just as a general rule, we should remember when we talk of estrogen, side effects are generally related to the dose of estrogen. So in other words, the higher the dose, the higher the side effects, which is very different from progestogens, and I'm going to go into that now. So the only naturally occurring progestogen is natural progestogen, and all other progestogens are synthetically produced and are called progestins. So the progestins differ from each other in the way in the potency of their receptor stimulation, whether they are pro-estrogenic or anti-estrogenic, pro-androgenic or anti-androgenic, etc. So depending on how they stimulate the receptor, you will get different effects. So the only natural progestogen, to answer the question that was earlier asked, is naturalized micronized progestogen, which has a unique pharmacodynamic and safety profile depending on the route of administration. And the synthetic progestogens are all analogs of this progestogen developed to make the hormone available orally. So they these progestogens bind to receptors for the glucocorticoid, androgen, and mineralocorticoid. And therefore you get the various side effects of progestogens, because when they stimulate a glucocorticoid receptor, it will lead to a certain side effect. And it's also responsible for the breast cancer increase in menopausal hormone therapy. So what I'm trying to show you by this slide is that the small differences in the structure of the progestogen will lead to differences in metabolism and pharmacological effects. So if you go back to estrogens, we said that the side effects are related to the dose, whereas in progestogens, it depends on which class of progestogen you're using. So I have to put in this basic science so that you understand it as we go along.
I know we need it. We need it.
Yeah. So the progestogen receptor, there are 2 isoforms of them called progestogen A receptor and progestogen B. And all you need to remember is the progestogen B is the positive regulator of the effects of progestogen, whereas the progestogen A receptor antagonizes the effects of progestogen B. So that's why you can have different progestogen ligands, which can act as either agonists, antagonists, or mixed, depending on which receptor they're stimulating. So when the progestogen binds primarily to the progestogen receptors, so the naturalized progestogen or micronized progestogen binds primarily to the progestogen receptor with very minor binding to the anti-mineralocorticoid receptors. Whereas if you take dihydrogesterone, which is a synthetic progestogen, it behaves in a similar manner to the natural progestogen. Whereas medroxyprogestogen acetate, which was used in the WHI study, binds to the progestogen receptor and to the glucocorticoid receptor. And noethistérone binds to progesterone, estrogen, and androgen receptors. So this shows you a diagram of the various progestogens. We don't need to dwell on it.
Sorry, firstly,
yeah.
just go back
Yeah.
to that diagram. I'm just
Yeah.
going to give everybody, there's lots, as I say, there's over 300 people have now logged on. I'm just going to ask them, many of them are registrars and trainees. They want to take, they've asked, can they just to take a screenshot and with little cell phones so they can take okay, they should be able to move on now. They would have taken their screenshots. Thank you.
So the progestogens, the synthetic progestogens, are subgroups depending on whether they are related to progesterone or to testosterone. So I'll just go back one slide. So we have, if you remember these progestogen derivatives, they either are related to testosterone or they are related to progesterone itself. So they have different side effects depending on the origin. So if you look at dihydrogesterone and micronized progesterone, the reason why micronization is done, it was done to be able to make natural progesterone available orally. So it had to go through a micronization process for that. And if you look at dihydrogesterone, which I told you is very similar to the natural progesterone, the only way it is different from the natural progesterone is that if you look at it, it is a bent molecule compared to this, which is a straight molecule. So it's the light technology which bends it into a curved, what they call a retro steroid structure. But because they are similar, they have similar effects. And I think you just need to remember that so you'll understand why their effects are similar. So what do we use progestogens in gynecology? We use it obviously in menopausal hormone therapy, menstrual disorders. We use it as medical therapy for endometriosis. It was first discovered, or the move to discover it was in contraceptive purposes. We use it in infertility treatments and for the prevention and treatment of pregnancy disorders. So it has a huge utility. So basically, estrogen alleviates the vasomotor symptoms. It prevents the vulvovaginal atrophy. It protects bone, the brain, and the heart. And the progestogens are used solely to counter the stimulatory effects of estrogen on the endometrium, and therefore it is only necessary if the patient has an intact uterus. So the next few slides that I'm going to go through is, I just want to look at a few seminal studies. I'm not going to spend a lot of time on them, on breast cancer. And I picked on what I thought were the studies that created waves when they first came out. And the first one was the collaborative group on hormonal factors in breast cancer. It appeared in the Lancet in 2019. It was an epidemiological study. And basically, they looked at 58 studies from about 1980 to 2017. And these authors' conclusions were quite dramatic. They said 5 years of daily estrogen plus progesterone started at the age of 50 will increase your breast cancer incidence by 1 in 50. And but when we looked at the study, when authors looked at it, they said if these associations are largely causal, then for women of average weight in developed countries, 5 years of menopausal hormone therapy starting at the age of 50 would increase the breast cancer incidence 1 in every 50 users of estrogen daily plus daily progesterone, 1 in every 70 users if you're using intermittent progesterone preparations, and 1 in every 200 if you're just using estrogen alone. So the message coming across from the study was that it's the progesterone component that is related to the breast cancer. But this study does not relate to menopausal hormone therapy regimes currently recommended, and it has limited data on regimens using estradiol plus micronized progesterone or dihydrogesterone. And it makes no attempt to balance the age-specific or overall risks and benefits of menopausal hormone therapy. So that was one study. Then there was a large French study called an E3N study, which looked at postmenopausal women in the age group 40 to 65, the age group that we treat. And they followed about 80,000 patients for about 8 years. And the they identified breast cancer cases in about 2,350 out of these 80,000 patients. And when they looked at it, what they really found was that if you look on the one side here, the baseline risk, if you look at estrogen plus progesterone and estrogen plus dihydrogesterone, there was no statistically significant increase in the breast cancer incidence. But when they compared it to other progestogens being used, the risk was statistically significant. So to put it in
just go back just that last one, Percy.
Yeah,
All right, so if you have estrogen and progesterone, it's the same.
It's almost the same as the baseline risk, because you remember that breast cancer also has an age-related factor. So as you age, there's a greater chance of you getting breast cancer. Yeah,
that's right.
So when they compared that with the estrogen plus progesterone alone, the natural progesterone, no difference. With dihydrogesterone, a small increase, but not statistically significant. When they looked at the other progestogens, it was a statistically significant difference.
Okay, that's 60%. Okay, got it. Relative increase. Okay, thank you.
Okay, so there is a difference. So the message I'm trying to give you is that there is a difference in the type of progestogen that you're using.
And the one you should use is micronized progesterone. Is that
it's either micronized progesterone or the dihydrogesterone if you're worried about the breast cancer. But as I'm going on in the presentation, I will tell you some of the other progestogens where they may have certain benefits. So it's not a question of just saying one size fits all. You have to look at your patient and decide which one will benefit them.
Okay.
That's why the topic is individualized treatment. So put it in another way, if you look at this E3N study, I want you to look at it carefully, because under 5 years, if you just use estrogen plus progesterone, the risk was non-significant. But once you started using even naturalized progesterone or dihydrogesterone greater than 5 years, it started to increase.
I see.
So as the E3N study followed the patients for a longer period, they did find beyond 5 years, even with dihydrogesterone and progesterone, the increase was beginning to become significant. But if you compared it to the other progestogens, it was far less. So up to 5 years, it appeared to have no difference, but for longer periods of time, there happened to be a small increase. This study is a great study because in the WHI study, they collected a wealth of information, and it allowed researchers to follow up these patients for a long period. So published in JAMA in 2020, they looked at the association of menopausal hormone therapy with breast cancer incidence and mortality. And they found after about 20 years, when they used estrogen alone compared with placebo in women who had a previous hysterectomy, there was a significantly lower breast cancer incidence and a lower breast cancer mortality. But when they looked at conjugated equine estrogens plus medroxyprogesterone and acetate, and obviously you had to use that in people who had an intact uterus, it was associated with the higher breast cancer incidence, but no significant difference in breast cancer mortality. So this lower breast cancer incidence that we saw in the conjugated equine estrogen group persisted for more than a decade after discontinuing its use. And this was in contrast to most prospective observational studies. And I'm only going to mention one prospective study here, observational study, the Million Women study, which most of you know, which was a population-based study based on mammographic screening. And they showed an increase in the risk of breast cancer with estrogen-only users, but it was greater with the estrogen plus progesterone users. So what I'm saying...
Sorry, Percy. The Million Women study. What estrogen did they use there and what progesterone?
Yeah, they used, it was a mixed thing, but there it was mainly estradiol. Estradiol, yeah. So it was mainly estradiol, but some of them was conjugated equine estrogens. But they showed that even in the estrogen-only component in that observational study, there was a small increase in the incidence of breast cancer. So in my next slide, I'm going to give you some reasons why I think the difference occurred. So one of the reasons for the decrease in breast cancer in the estrogen-only arm of the WHI is related to the duration of use, because they stopped the study after about 6 years. And remember, in the basic science slide on estrogens, I said that the conjugated equine estrogens have SERM-like effects, selective estrogen receptor modulator effects. By that I mean they have different effects depending on which organ they act at. And the other main reason is that the time between the onset of menopause and initiation of estrogen in the WHI study, remember they chose an older group who had never been on hormonal therapy. Their average age was 63 years. And we call this the gap effect. That means if you delay your onset of starting hormone therapy in patients and start them a few years later after the menopause, that leads to a decrease in the incidence of breast cancer. This is in direct contrast to the window of opportunity timing that we talk about for cardiovascular protection. So when I come to the cardiac slide, you'll see this. So if there's a delay in the time that you initiate your hormone therapy from the onset of menopause, if you delay that, there'll be a decreased incidence of breast cancer. There was another epidemiological study. This is appeared also in 2020. It was based on the general practitioner population studies in the UK. They have large databases, and basically they showed very similar findings, that if you use combined menopausal hormone therapy, you have 22 extra cases by 10,000. If you used hormone therapy in the past, it's 5 extra cases. Recent estrogen-only uses, they showed 3 extra cases, not like the WHI, which showed no increase, but there was no increased risk of death. And when they looked at the progestogens, the noethistérone component was the highest risk and dihydrogesterone was the lowest risk. So this study confirmed the increased risk of breast cancer associated with long-term use of estrogen therapy and combined estrogen and progestogen therapy. And the combined treatment associated with the lowest risk was the estradiol dihydrogesterone. So these findings suggest lower increased risk of breast cancer associated with longer-term HRT use and more noticeable decline in risk once treatment is stopped compared to the collaborative meta-analysis. So I've now finished the seminal papers that I thought reflected on breast cancer. And I'm now going to move on to vulvovaginal atrophy, which was even mentioned by Elna last week. And I think this is a progressive symptom that's underestimated, underreported, and undertreated.
Percy, can we just go back again
Sure.
to the previous one, just before we leave that topic? I just want to ask you over here. So your bottom line take-home message is you must start as soon as possible after the menopause onset. Is that one of your bottom lines?
No. So what I'm saying is that so we treat patients in menopause according to their symptoms. So not everybody needs treatment. So if a patient is highly symptomatic immediately at the onset of menopause, that's the time that we, as clinicians, we generally put them on hormone therapy.
Yeah.
What I'm saying is that if you got a patient, say, with a strong family history of breast cancer, and you delay from the onset of menopause, you delay some of her treatment until later when the symptoms become really bad for her and she cannot cope. Yeah. That delay or gap effect, when you delay the onset of your treatment, actually decreases their chances of breast cancer, which is in direct contrast to the cardiovascular benefits. We talk in cardiovascular benefits of what we call the window of opportunity. In other words, if we treat our patients in the first 10 years of menopause, from the onset of menopause, our cardiovascular benefits are maximized. Okay. So there's the difference between the two. So when I come to the concluding slides, I'm saying when you look at your patients who you think may be higher risk for breast cancer, maybe you should delay your onset of starting therapy. That's the message I'm trying to give.
Okay, because we've got a question here from Saida Ali. Please comment on the window period. So you've done that. That's good. And another question over here. Where can we get access to this presentation? And then you'll just email Karen, the one that does your CPD, and Karen will give you access to all these slides that Percy's doing. They're creating huge interest. And then Katrine Middleton says, please help with the treatment of vasomotor symptoms in, now hang on a minute, in the perimenopause. Well, you are doing that. These are all for vasomotor symptoms. That answers that question.
So the reason I concentrated on the breast part is that as clinicians, when we see patients with menopausal symptoms, the thing that dominates the conversation in our rooms is the breast cancer fear. So I'm starting with that, but I will mention some of the other aspects of the menopause.
Thank you.
So in vulvovaginal atrophy, this I really feel is, as I said, underestimated, underreported, and undertreated. And most other menopausal symptoms will be self-limiting. In other words, as the years from the menopause go, the symptoms on average for most patients about 5 to 7 years, it will probably settle down. But the one symptom that gets worse as you progress away from the onset of menopause is this dryness of the vagina, what we refer to as a genitourinary syndrome of menopause. And the reason why International Menopause Society changed the name from just vaginal dryness or atrophic vaginitis to genitourinary syndrome of the menopause is to emphasize the urinary component of the effects of the atrophy of the vagina and the bladder. So the bladder also undergoes atrophy, and many of the symptoms that we see in menopausal patients. I see patients sometimes that will say, I've had 4 episodes of urinary tract infection in the last year. I've had 4 or 5 courses of antibiotics, when actually the symptom may be just related to the dryness of the vagina. So you should remember that 1/3 of women can still suffer from vulvovaginal atrophy despite systemic hormone treatment. This is a very easy condition to treat with very few side effects. So this is an important part. So what about the safety of local estrogens? So basically, when they looked at the serum levels at the end of a 2-year period in a patient that was not treated with any hormonal therapy, and they compared it to the use of a vaginal ring or the 10 microgram vaginal tablet, the serum levels of the estrogen were similar.
That means it's not absorbed topically from the vagina.
Yes, and it's not absorbed, and it means that you do not need, if you're using only local estrogens, you do not need to give the patient any progestogen therapy, because the level of absorption is so low that it's unlikely to influence endometrial hyperplasia.
Okay, so we must talk about systemic absorption, because although it works topically, locally, yes, it's not systemically absorbed.
Yeah, it's not systemically absorbed to an extent. What we found with these is that initially, when you have severe atrophic vaginitis, when you initially use your local estrogens, you get an increased absorption initially. But by the end of the 2-year period, the serum levels are similar. So there's no long-term effect of you needing to give a progestogen in those patients.
And which estrogen should you
use? So it depends on the choice that the patient wants, because basically you can either use a cream or a vaginal tablet. Yeah. And I offer the patient both. We look at cost factors and we look at what's the patient preference. They're both probably the same effects.
So the cream is the what?
Is like the Menopause. We used to have Premarin cream, but that's almost unavailable now.
Yeah.
Yeah. So the only cream that I use now is Menopause. Yeah.
Okay, thank you.
Right. So just to summarize this, there's level 1 evidence that the addition of a progestin to an estrogen as part of menopausal hormone therapy increases the risk of breast cancer. I think that there's no doubt about. But you should also be able to recognize independent risk factors for breast cancer. So for example, if you do a baseline mammogram and you find that the patient has dense breasts, that's an independent risk factor. If she's obese, she's a smoker, that combination definitely increases her risk.
Are you a smoker, Percy?
No, no, I'm not.
And what about alcohol?
Oh, well,
not you. I mean the patient. Not you.
The risk of breast cancer is equivalent to of menopausal hormone therapy is equivalent to a patient having 1 to 2 drinks a day.
Okay.
So it's the same risk. So that's why we're saying when you relate your breast cancer risk in the counseling of your patients, you got to compare it to other risks so that they get an idea. And ultimately, they will make a decision themselves. I want to take this therapy because I see it's of value to me. Our job is to act as information providers, provide the correct information and let the patient make a judgment. Because after all, we're giving it mainly as a preventative medicine. So there's evidence from preclinical and observational studies that the use of a naturalized micronized progesterone or dihydroestrogen with estrogen is a safer option than synthetic progestrogens, in that they do not result in an increased risk of breast cancer when used up to 5 years, and a much lower risk of breast cancer than the synthetic progestrogens if used beyond 5 years.
So that's the topical estrogens, is you telling us?
No. This is,
I mean, the topical progesterones and estrogen.
Estrogens, yeah. So this is a general statement of where the progesterone. We're coming to the conclusion of the breast cancer episode now. So we're moving on to cardiac disease, and this is just one slide here to show you that if you start therapy in the 50 to 59 year group, it definitely you get a decrease in cardiovascular disease. In the 60 to 69 year group, it almost approaches neutrality, and certainly beyond 69 years, there may be negative effects. So that's why we refer to in cardiac disease, the window of opportunity, where you need to start it virtually at the onset of menopause. So in your symptomatic patients, you can reassure them that if you do start therapy, it's going to have a benefit for as far as the heart is concerned. In the WHI study, the reason why they showed an increase in the incidence of heart disease in the first year was most of these patients had already had established coronary atherosclerosis, and giving them hormone therapy, in fact, worsened their condition. So that was the older patient. It's not the age group that we normally treat patients. So that's as far as heart disease is concerned. Was this WHI figures supported by any other studies? Yes, it was. In the ELITE study, they showed where if you used hormone therapy for less than 6 years from the onset of menopause, it significantly reduced the progression of subclinical atherosclerosis. But in the late menopause, greater than 10 years, it had no effect on the progression of subclinical atherosclerosis. Just going to go through the other progestrogens. Medroxyprogesterone acetate, which was the product used in the WHI study, does not bind to the estrogen receptor, but acts as an anti-estrogen that dilutes the beneficial effects of menopausal hormone therapy on coronary outcomes. And this is one of the reasons why the WHI study showed an increase in cardiac disease in the first year, besides the age effect. What about thrombosis? So if you use oral estrogens, there's an increased thrombotic risk. And there's enough studies to show that if you use transdermal hormone therapy, your risk of thrombosis decreases markedly. The next question to ask, in the patient who has an uterus, does the choice of progesterone influence thrombotic risk? Well, it seems like micronized progesterone and pregnant derivatives appear to have an acceptable thrombotic risk profile. So I think if you ever have a patient where you're worried about venous thrombosis, then the transdermal therapies will be your first-line choice. So the contraindications to hormone therapy.
There's another question.
Sure.
This question of transdermal. Now, we know it can be given by patches. We also know it can be given by swiping up your arm and giving femigel. Yeah. Femigel and micronized progesterone, utrogestan. From a menopausal perspective, the Menopausal Society, you were the president last year. What is safer, the patch or the other one?
No, I think it's the same. I don't think there's any I've never seen any study which said the patch was superior for this or this thing. And there again, it comes down to, if I'm thinking of transdermal therapy, I'll offer the patient the both options, and often they will be the ones who choose, which one they prefer. Some don't, like for example, in the patch where you have the combined patches, some of them don't like to use a cream and then still have to take a tablet. So they prefer the patch, the combined patch. So a lot of this is once you give the patient the option, but there's no scientific evidence to show that one is superior to the other.
Thank you. And the next final question is, which is cheaper as a generalization? Some people work like me in difficult areas, inner city areas. Patients don't necessarily have money. Which as a generalization is cheaper of those two you've mentioned?
I think the patches are cheaper. Some of the patches, because when you're using Femigel, you're using it in combination with Utrogestin, and the Utrogestin is expensive.
Okay, thank you.
So I think you must take cost into consideration.
Thank you very much.
Sorry to interrupt you, Dr. Mudley. Just two questions that people have asked. They said that the lab sends them E2 levels in grams. How do you compare that to the milliliters?
How do you
What is the conversion? Does that make sense?
I think you're going to have to Google that, Corin, because
I don't know that.
Percy doesn't know off the top of his head. So we'll just have to Google that. What is your second?
And then the other one is, what about vaginal E2 or E3, which is better?
Yeah, now there's some work on the E3, and because it seems to have more local effects, it may in time, I think, prove to be an advantage. But at the moment, I didn't mention it too much because it's not really commercially available much. So therefore, my main use has just been the Menopause cream and the estrogen E2 vaginal tablet.
Is that Vagifem?
Vagifem, yes.
Okay, thank you.
Speaking of Vagifem, the other question is that a doctor gets from their patients. If they use Menopause or Vagifem, is there any significant side effects for the partner?
No, not I've noticed. It doesn't interfere in terms of sexual activity at all.
I mean, it's not absorbed by the male, is what she's asking.
No, it's not. It's not.
Okay. Thank you. Thank you. Please.
Okay. Just quickly, the contraindications, it's breast cancer or a history of breast cancer, any estrogen-sensitive tumors, like some of the endometrial cancers, vaginal bleeding, where you haven't determined the cause, untreated endometrial hyperplasia, active venous thromboembolism. If you have a history of a thrombophilic condition, such as protein C or protein S or antithrombin deficiency, this is a relative contraindication. And if you have to use hormone therapy here, you'll definitely use the transdermal option. Active or recent arterial thromboembolic disease, especially a history of angina or myocardial infarction, and liver disease, because most of these products are metabolized in the liver.
Percy, somebody said, just go back to those indications, the contraindications. So smoking and obesity is a relative contraindication.
Yes, definitely not a complete contraindication.
So you use as we said, the transdermal. Okay, thank you.
Yeah. So I'm just going to mention a little bit on brain fog in the menopause, because the white paper last year was on brain fog. And one of the authors on this thing is a South African, Nicole Jeff. Cognitive complaints are common in the menopause. And I find that when I see patients with this, they have an anxiety, especially fearing later life dementia. And the thing that seems to go for them is learning and recall of verbal material seem to be most commonly affected. But these memory difficulties resolve for many women post-menopause. So I think you can reassure them that if they have these memory defects in the early menopause, it's not an indication that they are going to get Alzheimer's disease later on. So I think that's important. And low education and social disparities seem to exacerbate the cognitive vulnerabilities. Obviously, it's intuitive.
Sorry, can you just put that in English? Social disparities. What is a social disparity?
So what they mean is in terms of social class. Yeah. So the lower social classes seem to have these cognitive vulnerabilities at a greater extent. And the reason for that is probably related to the fact that if you're using your brain all the time and doing things like crosswords and
Playing bridge.
and all, and playing bridge, etc. If you're using your mind, it'll be less. Whereas if you're just battling to live on a daily basis, then you don't have time for those things.
I understand. Thank you.
Yeah. And treating vasomotor sleep disturbances, mood issues, and all will help. But hormone therapy is not recommended as a primary indication for cognitive issues. So what you need.
Sorry to interrupt and keep interrupting.
No.
This is a lot of people's questions are coming through left, right, and center. Does it or does it not delay the onset of Alzheimer's? I think you mentioned Alzheimer's.
No, it does not. Yeah. So let's go back. In the WHI study, there was a subsection of that study called the women's faction, and they basically showed that if you use menopausal hormone therapy in the early phase, it had no influence on later onset dementia.
Okay.
But if you used it in the older patient, 60, 65-year-old, etc., if you only started there was an increase in the incidence of dementia in that group. So what I'm basically showing by this slide here, that if your patient has memory difficulties now, it doesn't mean that they're going to have a high incidence of dementia in the future. Okay. And how do you prevent it? It's more by looking at the modifiable risk factors. Make sure you treat your hypertension, prevent obesity, use your brain by constantly doing things, reading, doing stuff, and that will more likely prevent you from developing dementia than using hormone therapy. Okay, what about tibolone? Tibolone is a drug that has estrogenic effects, progesterogenic and androgenic effects. And basically, the breast tissue is not stimulated with tibolone. And I find that one of the areas where I use this is in patients who have mastalgia. If I put them on conventional hormone therapy and they develop mastalgia and I switch them onto tibolone, I find they do better. And the other main indication for it is the androgenic component has a positive effect on libido and sexual function. So
is that with everybody? I know they talk about it. And last week, Dr. Rudos stressed this. But I've put patients on tibolone, and some of them say it makes no difference.
I agree totally with you about that. It does not have a positive influence on every patient with sexuality, but it's the only drug that's approved for improving libido in the menopausal period. Whereas when we use testosterone, and I hope I can one day discuss this, we're using it as an off-label drug. So often I would start off, if sexual dysfunction is a problem, with tibolone, and if they don't have an improvement, then I'll offer them the testosterone alternatives.
Hang on, that's not sexual dysfunction, that's libido issues. What we
libido issues
are called hyperactive
sexual desire disorder.
Yeah,
that's what.
I always say to the woman that the man comes in and says, "There's something wrong with my wife's libido." I say, "Well, if you pick up your underpants, maybe she'd have more libido." But I think it's a two-way thing. It's not only her. I think it works two-way. Anyway, sorry, you carry on.
Yeah, and then if you look at levonorgestrel, just to remind you all, that's the progesterone that we use in the intrauterine contraceptive device. And lots of us would sometimes put this intrauterine contraceptive device into the patient in the menopausal period, so it decreases the amount of progesterone exposure that they have. This is a drug that we won't see in South Africa because Pfizer has now removed its application to the South African Drug Board for approval. This was a combination of a SERM, basodoxifene, and conjugated equine estrogens. I was really looking forward to this drug. It's been used in Europe for almost 10 years now. I was looking forward to this drug because I thought it may have a place in some of our breast cancer survivors, but this is not coming, but I just mentioned it. Drosperinone is a progesterone with an anti-mineralocorticoid effect, anti-androgen effects. So it's very good for, it has a favorable influence on cholesterol and triglyceride levels. It decreases blood pressure So if your patient is hypertensive and you're looking for an oral combination therapy, then you'll be able to find one in South Africa as a combined, and it's known by the name Angelique. Noethistone acetate, well, this is a common, one of our first progestogens, a lot of our hormonal therapies. And although it has progestogenic, androgenic, and estrogenic biological activity, and from a breast cancer point of view, wasn't great, it is very good for bleeding control. So I find that when I put patients on combined therapy in patients who have an intact uterus, maybe a year or so after they've completed their menopause, and sometimes they come up with acyclical bleeding or bleeding issues, postmenopausal bleeding, and they're still having a lot of symptoms. When you choose to a noethistone type of progestogen, you get far better control. But its main side effect is that of mastalgia.
Percy, someone says, how do you know Netta? What is its commercial name?
It's well, I know it is noethistone acetate.
Yeah, but is it Provera? Is it?
No, it's not Provera. It's no, it's not. It's oh, gee whiz, I got a brain lapse here. It's Primalote, I think, but I'll have to check that and I'll send it to Karen. Sorry about that. I just
no problem. One question here, sorry, doctor, is there any place for treatment of intractable vasomotor symptoms, etc., in a breast cancer survivor?
Yeah, I'm coming to that.
Okay, great.
Okay, right. Okay, so the next product is dydrogesterone, which we spoke about. It's available either sequential, where we use it as a 10 milligram tablet. When we use it continuously, the dose is lower. And now we even have a low dose combination of dydrogesterone, which is only 0.5 milligrams of estradiol and 2.5 milligrams of dydrogesterone. So many.
And what's that called commercially? Do you know that?
Dufastone. Dufastone. That's dufastone. So it's a combination of estrogen and dufastone. So some of my patients, even if they've been on other therapies and they're getting above 60, and I've had a trial of them without therapy and they still become symptomatic, I often switch them to the lower dose variety, because as you lower the doses, your side effect profile will be lower. So what are the general principles in administration? You must calculate the individual benefit risk, start with the lowest effective dose. Estrogen only if no uterus, with either estradiol or conjugated equine estrogen. You have to use progestogen in people who have an intact uterus. If you worry about breast cancer, then you must start with the natural progestogen or dydrogestogen. The most appropriate length of time is according to the indication. There's no cutoff period for the use of hormone therapy. Consider transdermal applications if at risk of venous thromboembolism, and avoid compounded products with adequate trial data. Right, so there are some new therapies coming up. I'll just spend a minute on this. They've discovered these neurons in the brain called the kisspeptin and the neurokinin system. And basically, when you look at menopausal patients, as soon as you have estrogen deficiency, you have an hypertrophy of the kisspeptin and neurokinin B systems. So we don't actually know what triggers the hot flush, but it's thought to be that these systems are involved in the regulation of the hot flush. So the hot flushes seem to coincide with the GnRH and LH pulses, and these pathways are critical for reproductive function. So what they've really found was that the neurokinin B is a key mediator of hot flushes. So at the moment, they've gone past phase 3 trials now, where they're coming out with these oral and NK3 antagonists. And this should attenuate menopausal hot flushes without the need for estrogen exposure. So coming to the question.
Sorry, just to interrupt you. There's a question here from Mike Suddens. I hope this answers your question, Mike. Next year, they're releasing in Southern Africa, I hope Zimbabwe as well, where Mike Suddens is. They're releasing these kisspeptin type medications. So they're useful for women that are breast cancer survivors because they control hot flushes without the need of menopause. So they will be safe for use in breast cancer.
Absolutely. So this is a drug that we're looking forward to and may be helpful in the future for our breast cancer survivors who have severe hot flushes, actually. Because
can't wait for this new drug, yeah.
Yes. So, so coming back to this NK3 antagonist, there are 3 in advanced phase 3 trials. So I just want to give people an idea of the success of various therapies for menopausal symptoms. If you use hormone therapy, you get about an 80% reduction in symptoms. If you use the selective serotonin reuptake inhibitors, it's about 40%. And that's similar to cognitive behavioral therapy, also about 40%. All these herbal remedies that are around are no better than placebo. And the placebo response is close to 25%. So even if you gave your patient Smarties, you'll get a 25% response. So
Percy, before we move off placebos and herbal remedies, is it important or not to monitor women that are on herbal remedies as if they were on hormonal therapy? As in
absolutely. That's
a
very relevant question. So I will have patients who come to me who are already on the therapy. And if they feel that they're confident on the therapy and they're getting symptom relief, I don't necessarily change them, although I won't prescribe it because they can buy this over the counter. But they need to be monitored in the same way that you'd monitor your patients on menopause. It is a falsity to think that they do not need to watch breast cancer issues, etc. with this, even with the phytoestrogens. So the NK3 antagonists are almost as effective as hormone therapy and superior to non-hormonal strategies. So we're all looking forward to this drug, but you must remember that although it will be decrease hot flushes, it won't have all the other advantages that conventional hormone therapy has as far as heart disease, joint pains, mood disturbances, etc. are concerned. But it will definitely be a treatment for hot flushes. I just want to end by saying there's very similar results between studies despite different methodological designs, different sponsors and chemical compounds. And I think this is, it augurs well for the future. And it's likely to have a particular role for those with contraindications or an aversion to hormone therapy, especially our breast cancer survivors. Thank you very much. And I'll end with this quote: if it ain't what you don't know that gets you into trouble, it's what you know for sure that just ain't so. Thank you very much.
Well done, Percy, and a great big thank you very much indeed. And at this point, also thank you to Abbott's, who are the sponsors, and they're going to be joining us with a marketing video, which Corin's going to play out with. Femoston, not all MHTs are the same. Are you with us? Special thank you then to Devin and Creason. Yeah.
Could we answer just a few more questions? They've come in like raging. And just to let everyone know, if your question is not answered, if we don't have time to get to it, feel free to email me. It's karen.bird@pffsa.org, and I will get your question answered for you. So one of the questions was, can we give the transdermal patch to women who have been postmenopausal for more than 10 years?
Yes.
Okay. And then please comment on the Mirena versus the Ustrastan in terms of breast cancer safety. I don't know if that's something that you can comment on.
So with the Mirena, one would think that the systemic absorption is lower and therefore would be safer in terms of the breast cancer risks. But there have been 1 or 2 studies that have shown an increase in the breast cancer incidence, even in patients on Mirena. So they need to be monitored. But intuitively for me, because the absorption, systemic absorption is less than giving an oral progesterone or progesterone, I would think that it would have some advantage, but it's not totally safe. You still have to monitor your patients.
And then there's from Graham Birdseye, The patch doesn't come with micronized progesterone or dydrogestin as a progesterone. So isn't it less ideal than oral Femigel and oral Eugestin?
No, Femigel is not oral. Femigel is transcutaneous, but we get the thing. Let's hear what Percy says.
Yeah, the Femigel is, we're using, with the Femigel, we're either using Eutrogestin or Dufastone, which has the breast protective effects. So the present patches that Graham is referring to, they don't have, he's quite right that they don't have the dydrogestogen or the naturalized progestogen in it. And therefore you sometimes have to choose, if you're worried in the breast cancer patient, IRS patient, I tend to use the Femigel Eutrogestin or Femigel Dufastone combination. Absolutely great question, Graham. Thanks.
And last one from Anarine Miller O'Neill. Is there a time limit for HT in post-menopause females, or do you continue whilst the symptoms still present?
Yeah. All the guidelines universally do not put a time limit now. But you know, when I get into the patients into the 60s, I try to lower doses and I try to see if they can manage without it, if they choose to. We have a trial period, and about at least 50% come back and say they're not coping and we have to go on. And if I don't have any other contraindications, I've continued. I've got some patients that are 15, 18 years on hormone therapy at the moment.
Well, Percy, it's been wonderful. Karen, is that the end of the questions?
Yes, from my side. If anyone has got missed or anything, again, just email us.
Okay, thank you so much. It's been wonderful having you, Percy. And you're now out of bandwidth, sadly. And I'm going to ask at this point a great big thank you to Percy Mudley and our sponsor, Abbott. And they're going to, Devon and Crescent from Abbott are going to be playing out with the marketing video. For Moston, not all MHTs are the same. Thank you very much. Good night and a safe trip home. Thanks, Percy.
June had always led an active life, but when she reached menopause, her symptoms caused her to feel isolated, affecting her work and home life. Medical societies recommend menopausal hormone therapy as effective or the most effective treatment for menopause symptoms. But not all MHTs are the same. In women taking estradiol and dydrogesterone, the ingredients found exclusively in Femiston, there is a lower risk of breast cancer compared with other combined MHT. And the risk of venous thromboembolism is lower than in users of other oral preparations, such as norpregnane-type progestogens, or no MHT. With proven benefits for a range of menopausal symptoms, Femiston can help June take back control of her life. Femiston makes her life better in post-menopause. Femiston is the world's #1 brand for estrogen deficiency in volume.
Thank you again, Dr. Midley. Goodbye.
Thank you.